Louis Simplicio. I'm a vitreoretinal surgeon in Newcastle upon Tyne. Thanks for attending this session. If you have attended the last one that I did a couple of weeks ago, was on a very different topic. Today we are back into the nitty-gritty of pure medicine and pure ophthalmic surgery. Let me just see if I can share my video with you. Should be all right. Right, so we are talking tonight about the treatment of aphakia and secondary IOL implants. Now, this is not going to be omni-comprehensive, so we will talk about some of the reasons and some of the techniques for the sake of time. But I think that the four that I've chosen are the ones who are definitely more widespread used at the moment and more relevant at this moment in time. These are my disclosures for this session. So the main reasons for aphakia, and again, I don't expect here to include all of them, but the four more important ones are really intraocular lens luxation or dislocation, intraocular lens removal, and later secondary implantation due to a specific reason. Most of the time now are chronic endophthalmitis. We have seen a surge of them, especially after we have started treating patients with intravitreal injections, trauma, of course, and some of the genetic reasons. We will be talking mainly about three techniques, so the anterior chamber IOL implantation, scleral fixation lens with two different techniques, and iris claw fixation. About all of them, we will see what are the pros and the cons, what personally I like and I don't like about those techniques, if I use them or if I don't, when and how. And then, of course, I would like to try to keep this session a little shorter, so that at the end, I hope that some of you can interact and ask questions or simply give me their insight on what's their preference and why. And if it's different from mine, by all means, I would like to be challenged and try to understand why, in your opinion, that technique is better. So, anterior chamber IOL, this is probably the oldest one technique. There are different types of IOL which can go in the anterior part of the eye. You can see one pictured here. It doesn't particularly matter. It doesn't particularly matter their shape, as long as they are designed to be fitted in the anterior part of the eye. We will start with a small video, and hopefully I will be able to pause from time to time to just highlight some important parts. So in this specific video, the surgeon started with putting trocars because he's a vitreoretinal surgeon. But the AC IOL can easily be implanted by a non-vitreoretinal surgeon, because in fact the vitrectomy is not mandatory, even if an anterior vitrectomy is usually suggested, and this can easily be done through the pupil. The second step is the surgical iridotomy. Surgical iridotomy can be done in very many different ways, scissors or in this case the cutter. In case you use the cutter, I would usually suggest to leave the cut rate very, very low at about 100 cuts per minute, and in a way that not to create such a large trauma to the iris. Surgical iridotomy is very important to avoid the pupil block. Some viscoelastic is helpful to create and maintain the anterior chamber, and in this specific video the surgeon decides to use a small slide. This is something that can or cannot be used. It's absolutely not mandatory. It's just something which can make your life a little easier if you have it, and it's entirely at a surgeon's preference. Again, some viscoelastic on top of the slide light will help with the lens, which is then slide inside using this device. Once the lens is inside the eye, the slide can easily be removed. The lens stays in place, as you will see in a second, and the distal part, the peripheral part of the lens is inserted inside the eye in the iridocorneal space. The whole surgery ends up with a couple of sutures because we have to create a usually 5.5 cut on the cornea. I'm going to stop here just a second because I want to briefly introduce a different kind of technique for the anterior chamber. I hope that you will be able to see my laser coming up, which is called sort of the frown technique. So instead of going corneal and create a big 5.5-6 millimeters wound, which indeed will create some astigmatism at some point, despite how good you are in stitching the cornea, what can be done is to create a frown, so a cut something like this, definitely bigger than the one that you create in the cornea, but in the sclera, and from here create a channel up to the limbus, and then with the blade go inside. You can easily slide the lens through this frown that you have created, and most of the time this is absolutely sutureless. So first of all, it doesn't create any astigmatism, and then most of the time you really don't have to suture the sclera, but you simply put the conch on top of it, and that's more enough to be watertight. What are the advantages and the disadvantages of the anterior chamber IOL? So first of all, the anterior chamber, believe it or not, is a very large space. So this is indeed an advantage, because once in a while, working in a space where you have plenty of it and you can maneuver very easily, indeed is going to make your life easier. And the surgery in itself is easy. Can be done pretty much by any surgeon at any level. The only skill that you need really is some suturing of the cornea and the ability to do an anterior vitrectomy. On the cons side, there is the possible vaulting of the lens, even if this is less and less frequent because the lenses are more and more modern, so usually they are very well adapted to the anterior chamber. There is a definite possibility of endothelium touch. This is true as a maneuver as you insert the lens inside the eye, and afterwards, once the lens is there, because the lens tend to be is at the iridocorneal angle, not only there but close to that space, there is a definite possibility that the lens can touch the endothelium, which of course can create endothelial cell loss, and this is due to two reasons. The first one is a mechanical reason. The second one is some sort of turbulence that the lens creates with the aqueous in the anterior chamber. There is the chance of pupil ovalization, but indeed with the anterior chamber is not so important. And of course, as we mentioned before, there is the chance of pupil block. So it's absolutely mandatory to create a surgical iridotomy to avoid this. Second technique is the scleral fixated IOL. Now, there are plenty of different types of IOLs. Some are very, very simple, standard 3 pieces lens. Some of them have holes to be anchored straight to the sclera. Some of them have different shapes. It doesn't particularly matter. The technique is always pretty much the same. I mean, of course, they are different based on different lenses, but the idea behind is always pretty much the same. And what changes really is whether you're going to suture the lens to the sclera, or whether you are going to use the haptics of the lens to keep the lens in place and anchor it to the sclera. So we will start with a small video here and see what we can describe. Now this is the what's called the Yamane technique. So it's a 3 pieces lens which goes through a tunnel in the sclera, but instead of being sutured or glued, it has a flange at the end which keeps it in place. I will show you. There are very many different techniques to perform a scleral fixation. It doesn't particularly, there is one of the questions that I'm always asked is clearly which one is the best technique. There is no best technique. The best technique is the one which works in your hands. So if you are happy with the standard one, by all means go ahead with that one. If you want to use any of the modified ones because they work better, please be my guest. So using this video starts using a toric marker. And this is useful, of course, to have to reference 180 degrees apart. Is usually, I would suggest a VR surgeon is probably best to do this kind of procedure because a vitrectomy is usually necessary. You can mark sorry, I want to pause a second and come back here. You can mark both the cornea and the conge. It's about 2 millimeters and then 2 millimeters apart. So those are 180 degrees apart, and this number 1 and this number 2 are about 2 millimeters anterior and posterior compared to the mark. And this and this, so number 1 and number 2, is exactly where the sclera will be punctured to then to let the haptic go through. Which IOL should I use? In reality, you can use whichever IOL you are comfortable with. Right? There is no better IOL one compared to another. There have been some studies, some comparison. At the end of the day, this is an art more than anything else. Whichever works in your hand usually gives very good result. In this specific case, the surgeon is using a 3 pieces IOL. So the IOL is inserted inside the eye and left hanging, oh boy, and there you go, and left hanging on top of the iris. I'll show you again. I'm not lucky today with this video. There you go. So at this stage, you have to create your tunnel. And which needle is it the best? Usually, a 27 needle is the perfect solution to that. So a standard 27 needle, you just puncture through the sclera. Then you grab your haptic with a pair of forceps, and you use the forceps to insert the haptic inside the lumen of the needle. Then you withdraw the needle, and of course the haptics which stays inside stays in place. You do exactly the same on the other side. This looks easy, I promise you, it's not. It's very fiddly. Again, you use a pair of forceps to slide it inside. You come out, and as you can see here, if I manage to stop it, the lens is perfectly in place with one haptic still inside the needle and one just coming out on this other side. At this stage, you remove the needle, you grab the haptic, and you create the flange by with a cautery. And this creates sort of a small button at the end of the small button, which is here, as you can see, and here. At the end of the haptic, you just push the haptic in this specific case, they have removed, of course, the hooks. You just put the button back inside under the conch, and that's it. Perfect. This is called Yamane technique. As I said, it's not the only technique which is available. You can use the same sort of technique to get the haptic out and then create a small tunnel which goes from here to there and slide the haptic inside, which then can be either sutured or glued. And there are very many different type of techniques. As I said, they all work fine as long as they work in your hands. So, which is the best, as I said, IOL for scleral fixation? As you can see, there are very many different types. It doesn't particularly matter. Again, it's important that you use the one that you are confident with. And just to mention, if you use one which is actually sutured to the sclera, I would recommend using Gore-Tex to suture the lens, because this seems to be the less sort of problematic material over time, because what's important is that what's risky is that you have conjunctival erosion over a period of a few years, and the Gore-Tex seems to be the one which creates less of an issue in this regard. So what are the advantages and disadvantages of the scleral fixation? So as an advantage, the IOL is very, very stable, all right? It's very unlikely that you will ever see it tilted, and it's very unlikely that it dislocates again, even after some trauma. Of course, it depends how big this is, but generally speaking, they stay in place fairly well. There is definitely no iris-related issue, no endothelial loss, and there isn't the risk of a pupil block, because this lens sits well behind the iris. And it's possible that you can use a pre-implanted IOL. So if you had a 3 pieces IOL, which was implanted donkey's ears ago and simply fell in the back of the eye, I've seen more than one colleagues of ours being able to retrieve it, clean it around from any remnant of the old capsule, etc., and use it to be reimplanted. In my opinion, it's a little bit hardcore, but it can indeed be done. What are the problems with this technique? It's fiddly. There is nothing to say. You see a video, if you go online and you Google videos, you see all these fantastic videos of 5 minutes. I promise you, these are very, very edited. It's very possible that the haptic snaps. It's very possible that the haptic, once you have created the flange, anyway, it comes back inside the eye again. It's never so easy to insert the haptic inside the needle. So this is a very fiddly technique, and it's incredibly time-consuming. Personally, I don't use it very much, and it takes me, probably that's one of the reasons that it takes me forever to do it. But I've seen people who constantly praise this technique and always use this technique, and it takes them time. And when I say time, it means, I don't know, 1 hour plus to do the procedure. It's always very time consuming. Indeed, you need a VR surgeon, because this is properly behind in the posterior part of the eye. So if it falls, or if you need a vitrectomy or whatever it is, you need a VR surgeon either doing the procedure or available very quickly at request. And of course, the problem related to the erosion that we have mentioned before. So, starting from this point, a good friend of mine, an Italian chap called Carlevale, has come up with a brilliant idea, which is the Carlevale IOL. So this is a lens. You can see the specs here. It's a monofocal IOL, standard dimensions, is hydrophilic, has a very wide range of power from -5 from +35, and it's also available in a toric version. So what was Carlo's thinking? His thinking was exactly like mine. Scleral fixated IOL do work very well, but they are incredibly fiddly and they take an awful amount of time. Fair enough. So let's sort of understand why it takes time. It takes time because it's difficult to insert the haptic inside the needle, and it's difficult to work with two hands on two sides and make sure that the pushing and pulling that you do on the lens is good enough but not strong enough to snap the haptics. So, having identified the issue, he's come up with one of the brightest idea ever, which was to eliminate this issue altogether. And this is the lens that he has created. The lens is a standard lens with this sort of VU, I don't know how it's defined, shape haptic, and with this T-shape end of it. This one goes outside the eye through a small hole, and of course once it's out it opens up and keeps the lens in place. I'll show you a video about this. Again, this is a modified technique from the original one. I'll tell you what the difference is, but it doesn't particularly matter related to this specific explanation, because what's important is the lens itself. So first of all, you have to start marking the conge and the cornea 180 degrees apart. It's very good that you mark both of them with a little sort of scratch of a needle and a mark, so you know that it's permanently, I mean, at least for the time of the surgery there, and you won't miss it. So you start marking the axis 180, then you carry on doing some conjunctival dissection, temporally and nasally. Of course, you want to have an operating area as clear as possible, so you will likely need a little bit of diathermy to stop any sort of bleeding and to make your life much easier. Now, let me pause here a second. This is, as I said, is a revised technique. The original technique that Carlo proposed was to create a scleral port here. So 3 per 3, something like that. So 3 millimeters per 3 millimeters, and create a port here and here. This is a revised technique, so there is only one single cut done in the middle, and then with the crescent blade you can create a small pocket inferiorly and a small pocket superiorly to this cut, and you'll see it in the video right now. This is a quicker technique which has exactly the same results as the original one. So a small cut, sort of 2/3 of the thickness, and then you create a small pocket inferiorly with the crescent. This is even too big in my opinion. A small pocket superiorly, at this stage would be already big enough. It's very generous, and you can see here on the diagram. Then of course you need a vitrectomy, because you will be working in the back of the eye, and the lens is going to be behind the iris and in the back of the eye. At this stage, it's one of the most important part, which is the creation of the tunnel. You have to go 1.5 millimeters posterior to the limbus, 1.5 millimeters here, 1.5 millimeters there, and with a 25 gauge needle, you have to puncture through the sclera. All right, so it's very important that the needle is a 25 gauge, because it's the one which fits best with the instrument and the one which fits best with this T-shaped haptic that the lens has. You go parallel to the iris. Here we are trying that the forceps go through. Specifically, in this case, a pair of straight forceps are used. I usually don't use a pair of straight forceps. I use a pair of curved Chariot's forceps, for the same reason is that if you see here, it's likely to be a man with a sort of a quite large face. There is very much space around here. But if you operate on someone who has tiny eyes or deep set eye, or women where usually the space is not as much, with a straight pair of forceps, you really struggle, especially on the nasal side. So my suggestion would be to use a pair of 25 curved Chariot's forceps, or whichever you want to use. But that would help definitely with your surgery. At this stage, the lens is loaded inside the cartridge. It's not preloaded, of course. It's very easy. The cartridge comes and the injector comes together in the package. You just put it inside with a little bit of viscoelastic. You close, and that's the end of the story. That's nothing particularly tricky or fiddly or anything that any of us hasn't already done before. You advance the lens a little bit. 2.2 or 2.5 incision. You go inside the eye with your forceps ready to receive the lens, and you start injecting the lens slowly, because oh boy, let's see. Apologies. Right, so here we are. So 2.2 or 2.5 blade, you start injecting very slowly the IOL, because what you need to do is you need to be able to grasp the T. Let's see if we are able to see it here. There you go. I will not stop it anymore, because I don't know why this is not working as it should. So you'll grab the T haptic at the end, gently, and then you pull it out the eye, and you simply leave it hanging there. There you go. So it's very important that you do this maneuver very slowly, because if you do it too quickly, the lens jumps inside the eye. See how quickly it opens up. And if this happens and you haven't grabbed it, it's difficult then to save the situation. You just put the T outside and you leave it there. You clearly go on the other side. You grab it, put it inside, behind the iris. You grab it with the second pair of forceps, and you pull it outside. You can see how much torsion he is using on the left side on the forceps, because they are not curved, they are straight. So he has to create lots of force there. Once the haptic is outside, you simply slide it inside and under the pocket that you have created before, and then you can either put a stitch, or more likely a little bit of glue on top of it, or in fairness, even nothing most of the times. And the lens is beautifully in place, and it's going to be there and stable forever. Now, what are the advantages of this lens? It's a scleral fixation, so as before, the IOL is going to be very stable. There will be no iris-related issue as before, and it's indeed much easier than the Yamane technique. It's not super easy. You need a little bit of learning curve at the beginning to know exactly how to handle the instruments and the insertion of the lens, because as I said, it's beautiful, it's very smooth, it goes inside the eye in a second, which is very good and very bad at the same time, because if you go too quickly, this is going to open up immediately, and then you lose it and it falls in the back of the eye, and then you run into trouble to recover it. So there must be some sort of balance that you have to learn. It's still time consuming, but definitely better than the scleral fixation, and still a VR surgeon is needed, because you have to do a vitrectomy. There is still the possibility of scleral erosion, but indeed, if you put it either under a scleral port or inside this small pocket, you really minimize minimize this chance to the bare minimum. Now, this Carlevale lens has been around only for a few years. I think it's 2-3 years, something like that, probably 4. So we really don't have long-term follow-up. So for the moment, to my knowledge, erosion hasn't really been an issue at all, but it might well be if we are talking about 10-20 years down the line. So this is something simply to take into consideration. It's not super cheap. It's a lens which has its cost. It's definitely way more expensive than a standard 3 pieces IOL. So this may or may not be an issue for you based on the hospital where you work, but indeed it's something to be taken into consideration. But kudos to Carlevale, who indeed has invented a beautiful piece of equipment which is making our life much easier. Last but not least, iris claw IOLs. Now, believe it or not, the artisan lens, as everybody knows them, have been around since 1978. They are as old as me, pretty much. And of course, they've gone through quite a lot of design change over time. And the one that you see on the right is the standard artisan technique, the standard artisan lens that is available at the moment. It goes inside the eye through a 5.5 cut on the cornea, has a power dioptic power from 2 to 30, and it's made of PMMA. And its characteristic, of course, is exactly those 2 cuts here, one here and one there. It means that these haptics are not just one haptic, but it's 2, and it's where the iris is gonna claw where the lens is gonna claw with the iris. I'll show you a video, if I can. This is one of mine done with ingenuity. I would like you to pay attention to the quality of the images with the ingenuity as well. So this starts with, of course, some trocars, because you have to do a vitrectomy. This has a patient who has a dislocated IOL. I'm not a big fan of trying to put the things back in place when they are dislocated, because experience is that then eventually I have to go back and do a second and the third operation because it dislocates again. So when I am in that situation, I usually simply get rid of the old lens and do a secondary implant, which in this case is an iris claw. Vitrectomy, standard vitrectomy, not particularly enlarged, whatever I can do without indenting and without risking too much and pushing too much. I use 2 blades. It's a 2.5 blade standard, and followed by a 5.5 blade. It's a brilliant blade which is exactly made on purpose. Of course, I have to remove the IOL which is already inside the eye. This doesn't sound, and it's not anything particularly tricky. You simply grab it, you pull it, and that's the end of the story. At this stage, you insert the iris clip. Now, let's pause. Let's see if this works. I skipped a bit in editing this video. So here and here I have created 2 paracenteses with an MVR 25, 23, whatever, 20, whatever you want to use. It doesn't particularly matter. So they have to be 180 degrees apart. Why here and here? There is no reason. Could be here and here, could be there and there. It's whatever you are sort of used to, and whatever works best in your hand. In my opinion, and to handle the lens as best as I can, it has to be 180 degrees, so let's say east-west. So I insert the lens, of course, north-south like this, and then I rotate it east-west. But the lens can go in whichever position you prefer. So insert inside the eye, rotate the lens 180 degrees, as you can see here with a little dialer. There you go. Lens is in position. You grab the lens with a specific pair of forceps, artisan. You dislocate it posteriorly, and simply with the same cannula that you have on the viscoelastic, or by all means, whichever instrument you want to use, you go inside the eye and clip and that's done. You swap hand, go on the other side, go inside the eye, and click. And that's the operation done. You see, the lens sits beautifully in the center. Now, there is one thing, is not bragging, but what's important here is this number up here. Now, this video may have been short, all right, and it's just a minute or so, but this was the time of the operation. This operation took 15 minutes start to finish, all right? It doesn't particularly matter whether you are quick or slow, but what's important is that if you work in whichever environment, you want to maximize the time that you have available and do as many operations as you like. So my sort of thinking is, why would I invest or waste, let's say invest 1 hour plus of my time to do a scleral fixated IOL, which has exactly the same kind of results as an iris claw, when I can do it in 15 minutes. Now, fair enough, we might argue that here everything was absolutely spot on, and that's not the rule. Fair, good observation. Usually doesn't take me more than 20 anyway, all right? So that's the kind of time which is needed to do an operation like this. The results are amazing. I have implanted, I don't know, 200-300 of these iris fixated IOLs. Results are very, very good, and complications are very, very little. We have some probably 10% of CMO, which always invariably resolves with a little bit of treatment. And what's important is that I can, because I work in a public hospital, I work in the NHS, I can look after 3 or 4 patients in the morning if I have enough time, because the procedure doesn't take me so long, compared to just 1 or 2 if I have to invest 1 or 2 hours for every procedure. So what are the advantages? It's easy. Anybody can do it. And when I say anybody, I mean it, because I always and only use it posteriorly. But lots of colleagues of mine, including 2 VR surgeons exactly in the same place where I work, they use it anteriorly. You can put it easily anteriorly, and there are some instruments which are called VacuFix that you use to sort of suck the iris up into the lens to claw it. It's very, very easy to do. So this is if you are let's say an anterior segment surgeon, or for a reason or another you don't want to use it posteriorly. Otherwise, if you are a VR surgeon or you are confident to use it posteriorly, you can easily do so, even if you don't really have to do a complete vitrectomy. You can just do an anterior vitrectomy. It's very quick. It takes me 15-20 minutes. It takes my fellow half an hour. All right, so it's a very quick technique. It's indeed not very expensive, because artisan lenses aren't particularly expensive, are more expensive than a standard 3-pieces lens, but definitely less than a Carlevale lens. So this is something, again, which may or may not be of any interest for you, but it's something to be taken into consideration. And the result usually is a very good visual acuity. Now, I have a small trick to tell you, and then I've seen a question coming through which I didn't really manage to read, so we will go to that in a second. The trick is that you need to know if you are going to implant the lens posteriorly or anteriorly, because there are 2 different settings on the biometry. Because if you use it posteriorly, the lens has to be upside down compared to when it comes out from the package. This is why, because the lens has some sort of vaulting, and if you put it sort of straight in behind the iris, you're going to get a pupil block. So you have to use it upside down, which is absolutely fine. It doesn't create any issue whatsoever. It's not any kind of complication. Simply you have to have two different settings on the biometry, and mine is simply called artisan anterior, artisan posterior, and gives you two different powers. Possible issues with the lens is CMO. This has been demonstrated many times, but in our practice is probably something around or less than 10%, and over 200 to 300 lens implantation, I've never had a permanent CMO. Most of them resolve very quickly. Some of them take time, but eventually they have all resolved. Of course, it likely needs a vitrectomy, or at least an extended anterior vitrectomy if posterior. If anterior, there is no problem whatsoever. There is a distinct possibility of pupil distortion, but it's more theoretical than real. In fact, in this case that I've just shown you, the pupil at the end was absolutely beautifully round, and that's not uncommon. That's pretty much the rule, all right? And there is a possibility of pigment dispersion. Yes, that's indeed true, because of course this is a lens which sits on the iris and pinches the iris. So of course there is a possibility of pigment dispersion. Does this create problem? I have seen one patient who had very bad sort of glaucoma kind of problem to start with. I can't quite remember what the exact situation, what it was, and eventually he ended up having it removed, because this, even if it was not massive, but this small amount of pigment dispersion that it had was enough to create him a problem. So let's say this was the biggest issue that I've had over years and years of implanting this lens, was removing one for this specific reason. Right, now I think this brings us to the end pretty much. So I will happily answer the questions that have already come through, but I would also like to know if any of you use any of these techniques, if there is one that you prefer, or if you use more than one, and why. And thank you very much.
Sandra, thank you. That was a really fantastic presentation. The first question that's come in, where is the ideal position to grab the T at the end of the Carlevale lens, the vertical or horizontal part, to reduce damage from manipulation? Right.
Let me go back here so I can. I think, Laurie, if you get back the presentation yourself, so I can stop sharing my screen. I think that would be great, and then I will answer the questions. Oh, perfect. Right, sorry, can you read it again? So you said which is then?
So it says, where is the ideal position to grab the T at the end of the Carlevale lens, the vertical or horizontal part, to reduce damage from manipulation?
Yeah, so you can see me, correct, on the screen, so you can see myself. Perfect. Yeah. So if the Carlevale lens, the end is done like this, the best to grab it is exactly here, is at the hinge between the horizontal and the vertical part. That's where it's strongest. And that's not the only reason. It's, first of all, is where it's less likely that you will ever snap it, but in fairness, I mean, you would really need to pull hard to snap it. But it's because if you grab it on a side, then it becomes difficult to get it out of the eye, because it sort of folds like this, and here, of course, it becomes double. It doubles up with the vertical part, and it doesn't come out. So you need to grab it from here, so that when it comes out of the eye, it folds like this, comes out, and it opens up again. So at the hinge is the best part to grab the lens.
Do you use intraocular or periocular steroids?
Sorry, Laurie, I can't hear you anymore.
Oh, can't you hear me? Can you hear me at all?
Yeah, not perfectly, but yeah.
1 minute. Let me plug this in. why I have this. Better?
Oh, now you go.
Do you use intraocular or periocular steroids for persistent CMO not responding to topical treatment?
Yeah, I think he's talking about the artisan lens. I have never, because I've always, well, it's not true. I've always had very good results just using some sort of topical steroids, or combined sometimes with ocular or stuff like that. And one case who had a very long-term CMO, I have used a sort of subtenon kind of injection once. It settled, and to my memory has never come back. So I think I've used it once, but I wouldn't definitely consider it as a rule. I would definitely consider it as an exception, because in fairness, they usually with the topical steroids, they just do well.
Okay. There are some comments as well. So somebody did comment when you were doing, I think it was a scleral fixation. He was saying if IOL is not placed in the right place, IOL can rub the iris and can cause PDS. I agree, it is fiddly. I've seen some taking 90 minutes.
I agree with the comment. There isn't much to say about that. Yes, and again, I think I'm not the biggest expert of scleral fixated IOL, I have to say, but from what I've done and my understanding and chatting with people who do it often, what's crucial again is the distance of sort of the tunnel from the limbus. So you need to be at the right distance, because if you are a little bit too shy and you come too much towards the limbus, is when you can definitely have this kind of issues. So that distance which is about 2 millimeters, 2.5 millimeters, seems to be fairly crucial to me to the good result of the operation.
Okay. There is another comment. So there are ready-made kits to do sulcus IOLs, IOLs, and they are pre-bent at the right angle to make it easy. Does that make sense?
Is it a statement or is it a question?
I think it's more of a statement. I think
all
they're
right,
just
because
saying they're ready-made kits.
All right, I have never come across, so very good. It would be very, very nice if whoever has made this comment has a link that can post in the chat. Oh, perfect. Because so we can see what they are, because it would be good for me as well, because I've never come across anything like that.
Absolutely. Then there is a question here as well. For standard AC IOL, should we measure WTW in each case or use the standard size in IOL? Because sometimes we may have to use the AC IOL as an emergency.
Yeah, so ideally, he's absolutely right. The wide to wide would be crucial. Would be very important. Now, I think that there is a balance here. So, if the eye is pretty much what we can call a standard eye, all right? So it's not super myopic or incredibly hyperopic, so it's sort of standard power. I think you may be good enough just using the standard lens at the first operation when you need it, let's say, and be good with it. If you think that the eye is sort of towards the extreme, it's probably best stopping a second and asking yourself the question if you are doing the patient a favor to just use the lens that you have available, or it would be better to leave him aphakic, let's say, and then do a second operation a little while down the line using a lens which is tailored to him. So if it's a standard eye, I'm fairly confident that you would be good with whatever you have available.
Okay. Somebody's left a comment saying thank you, very interesting. And
appreciate.
Here we go. There is more questions. What instrument were you using for endovation in the video?
Oh, it's not an instrument. It's the Rycroft cannula, which is on top of my viscoelastic. So it usually comes down like this. I use a pair of artery clip and I sort of bend it almost 90 degrees, all right? And then I go inside the eye through this 23-25 gauge MVR blade paracentesis I've done before, and I use it to enclavate. Now, another chap, a friend of mine in Italy, has come up with a very smart technique. I've never used it, but it looks great. So he passes a 10 nylon straight needle from one side to the other side of the eye on the cornea, like this, boom. And then he goes underneath with the artisan under the iris and use that to clip left and right in just one maneuver. It looks beautiful. I've never done it because, apologies, but myself, like all the surgeons, we are very conservative. So whatever works in our hand, we tend to use it for the rest of our life. But it looks really smart. But again, the key message is it doesn't matter. You can use whichever instrument you like. I use that cannula for the simple reason that it's there, it's already open, it costs nothing, it's there available. Whether I use it or not to enclavate is already on the table. So I think it's pointless to ask for a specific instrument when all that you need is something really which is big enough to push the iris inside and create the enclavation.
Perfect. Well, there have been a couple more comments. Both of them are just saying really informative thank you, and thank you so much for a really good session.
Thank you.
I can't see any more. Let me just double check that there are no more questions, and I will just check that no one has raised their hand because I haven't checked that yet either. I can't see. So with that, I would just like to say thank you so much, Sandra. It's a really fantastic session. And to all of you, thank you for joining us on a Friday evening after a very, very busy week at work for an educational session. We will be having another session next week. And as I said before, please do check out www.alconexperienceacademy.com, where there are a lot more sessions on there for you. Have a lovely weekend. Have a lovely weekend, Sandra. Take care, everybody. Good night.
Take care. Bye-bye. See you next time.
See you next time.